So when looking at urine, there are different characteristics of urine that can clue you in as to the nature of the body in terms of how well the kidney may be functioning, and in terms of how well the kidney may be concentrating urine as well. And so one thing you can look at is simply look at the amount of urine, right? And so typically a normal kind of urine production is somewhere around 25 to 30 milliliters per hour or so, and this is going to vary depending on sex. It's going to vary depending on size. It's going to vary depending on the state of the kidney. So are they diseased? Are they normal? It's going to depend and vary based on how much the patient has had to drink over time. So there's lots of different things. It can vary depending on diuretics as well. Diuretics are medications that promote the loss of water and urine, so they're promoting urination. So you'll see more urine in patients who are taking diuretics. And so with this urine, you can look at and determine how well somebody is hydrated, and then from there you can determine if any interventions need to be made in terms of their hydration status, blood pressure, things like that. Right? Different conditions such as diabetes produce something called polyuria, which is the production of an increased volume of urine. We'll talk about in a second. Something known as diabetes insipidus, in which there is a decrease in the amount of antidiuretic hormone that is produced. And so antidiuretic hormone causes you to reabsorb more water, so you're urinating less. But in diabetes insipidus, you are deficient in that, or you lose sensitivity to that hormone, so you're then producing more urine that is more dilute. And we'll talk about another one known as SIADH, which is kind of the antagonist to that, or the opposite of that. Another thing you can look at is the pH of the urine. So essentially you're looking at the acidity level, right? So typically the urine is slightly acidic, but it can range anywhere from 4, 4.5, all the way up to 8 on the pH scale, with 4.5 being obviously lower, it's being more acidic, and then 8 being a higher pH, being more alkaline or more basic. One large determinant of urine pH is our diet. And so if we are more acidic and large amounts of protein in our diet and lots of wheat in our diet, we'll tend to have more acidic urine. It'll be less acidic with a diet that is more plant-based, more fruits and vegetables. This tends to increase the pH, which is decreasing the acidity. Another factor influencing pH of the urine is the pH of the blood, right? And so if we are in a state of acidosis or a state of alkalosis in the blood, this is then going to influence the state of our urine in terms of its pH. So if we have acidemia, so if we have too much acid in the blood is too acidic. Normal pH of the blood is somewhere between 7.35 to 7.45. If we tend to get too low, we're in the acidosis range, acidemia, then we can begin to secrete and ultimately excrete more hydrogen ions in the urine, so that increases the acidity level of the urine, and thus helping with the acidity of the blood. Or if we're alkalotic in the blood, so we're too basic, we can reabsorb more, perhaps more hydrogen ions, or we could secrete more bicarbonate or filter out more bicarbonate, and thus help with the pH of the blood, and that would then influence the pH of the urine itself, right? And then the last thing we can look at is the specific gravity of the urine, right? So specific gravity is a measure of the density of urine relative to the density of water. Water, if we're just referring to kind of pure water, water's specific gravity is 1. Okay. Anything that is greater than that is referring to something that is more concentrated, more dense. So there's more things in the water. And so if you think of urine, although urine is largely water, it's almost entirely water, there are other things in the urine that we don't have in just pure water. So things like electrolytes, things like urea, maybe amino acids or fatty acids if we're needing to ultimately excrete some of those. If you have conditions such as diabetes and you have glucose in the urine, if you have kidney disease and you have protein in the urine, all of these things are going to increase the specific gravity of the urine. So a normal specific gravity is anywhere from kind of 1.001, 1.003, all the way up to 1.035. So kind of anywhere in that range is typically normal. Obviously, as you get closer to the 1.035, you have more things in the urine. As closer you get to 1, you have less things in the urine relative to the amount of water. And so if you think of your hydration status as an example, your hydration status is influencing the amount of water in the blood, which is influencing the amount of water in the urine. And so this is going to influence our specific gravity, right? And so if we are more hydrated, right, we have more water, we'll have more water in our kidney, we will have a lower specific gravity because we're essentially diluting our urine more, right? And so you notice the color of your urine when you excrete urine. If you are well hydrated, you drink lots of water all day, your urine tends to be a kind of pale yellow or a more clear color. Whereas if we're dehydrated, right, we are having less urine produced because we have less water, less volume, but the volume of urine that we do produce is more concentrated, right? So there are more things in the urine, more electrolytes, more urea, whatnot, relative to the amount of water. So the density in this case, or the specific gravity, urine specific gravity, would be increased. It would be closer to that 1.035, something like that, right? And so I mentioned a second ago diabetes insipidus and something known as SIADH. So diabetes insipidus is a case in which you are, it's a condition in which you are you have a decreased amount of antidiuretic hormone that is being produced, or you have lost sensitivity to it, right? And so if ADH is promoting the reabsorption of water, which would lead to decreased amounts of urine, diabetes insipidus would lead to increased amounts of urine being produced. That is very dilute, right? So you're losing a lot of water in the urine. And so this would cause the specific gravity to decrease, right? It'd be very low, okay? Now, if you have SIADH, which is known as syndrome of inappropriate antidiuretic hormone, you have an increased amount of ADH being secreted. And so if you have an increased amount of ADH, you have increased reabsorption of water in the DCT and collecting duct. So if you have increased water reabsorption, you're going to have less water in the urine, whereas you would have more solute. So ADH is not influencing solute reabsorption, but just water. And so in this case, you would have an increase in the urine specific gravity because you're decreasing the amount of water relative to the number of solutes, right? So keep all of these things in mind whenever you are, when you're studying, when you're looking at urine, and whenever you're thinking about what factors can influence the characteristics of urine, right? So when we talk about urine, we then talk about it leaving the kidney, right? And so we said by the time it flows through the renal tubules and the collecting duct, once it enters into the calyces of the kidney, so the minor and major calyx, the renal pelvis, it's urine. It's final urine. No other additions are made after it leaves the renal tubules, right? And so the first structure it leaves, or the first structure it enters after it leaves the kidney, is the ureter, right? So the ureters are the long tubular structures that extend from the hilum of the kidney all the way down to the bladder, right? And the ureter, like many other tubular structures we've talked about, so like stomach and the GI system and things like that, have different layers, okay? So one layer that we can look at is the mucosa, right? So this is this deepest layer. This is this layer consisting largely of a transitional epithelium, which is sometimes referred to as urothelium. This inner layer here, that's our mucosal layer, right? So if you recall, when talking about histology, the transitional epithelium has a variety of kind of cell shapes that permit the stretching and the distension in order to accommodate an increase in urine that would be flowing through the ureter and then entering ultimately into the bladder, right? And so there are times in which lots of urine may be flowing through the ureter. There may be times where there's a decreased amount. And so the lumen, or the size of the opening of the ureter, is going to change in response to that. And this urothelium helps with that, right? Now, so go more superficial to that, and you get to a muscularis layer. So this is the smooth muscle layer here. This is a layer of the ureter that is going to contract in response to urine passing through the lumen, which is going to stretch the smooth muscle, which is then going to cause a reflexive contraction of the smooth muscle, and this essentially helps propel and move the urine down the ureter toward the bladder. Right. You also have some help with gravity as it flows from the kidney down the ureter ultimately to the bladder. Right. And then lastly, you have this outer adventitia layer, this loose kind of fibrous connective tissue on the outside that helps to anchor the ureter in place to surrounding structures. If you recall, the kidneys are retroperitoneal, as are the ureters. These are all retroperitoneal structures. So you have a layer of adventitia that covers the kind of anterior surface, and it's more of kind of a binding tissue. It kind of anchors the ureter in place so they're not just floating and moving around in the retroperitoneal space, right? So as you move down, the ureters then begin to enter the bladder, and they enter into the posterior margin of the bladder. So here's one ureter on so our left, but the patient's right here. You'd have one on this side as well. And where they open in these kind of corners called the ureteral openings, right? And these are where the ureter comes in, it passes through the wall of the bladder, and then it projects into the lumen, and then urine is then entering into the bladder itself. Now, when looking at the bladder, you see some similar features that you also saw in the ureter. So you see an intermucosal layer. It is also lined with the transitional epithelium that allows it to stretch in response to distension from urine. You also see in the bladder, you see what are called rugae. And the rugae, you can almost think of similar to the rugae in the stomach. The rugae are allowing for additional stretching and distension and expansion of the bladder as you fill it with urine, right? You have this triangular shaped region here known as the trigon of the bladder, and then from this trigon it kind of funnels down into the urethra, and then from the urethra it will pass out of the body, right? Now, lining the wall, so here's our bladder here, this kind of brown hollow structure. In the middle layer here, this middle wall here, this is known as the detrusor muscle, and this is smooth muscle that can contract in response to the distension of the bladder that helps to force and kind of expel the urine out of the bladder. So you can think of, as this muscle contracts, it causes the size of the bladder to decrease. That's going to increase the pressure in the bladder, and then that's going to force the urine out of the bladder down into the urethra, and then ultimately out of the body. Okay. Now, for our bladder, we have a couple of different muscles that are going to be involved here. Some of them are voluntarily controlled, some of them are involuntarily controlled, right? So the first one that we'll see is known as the internal urethral sphincter, right? So a sphincter is just a kind of circular ring of muscle. This is referring to an internal sphincter, so it's deeper in the body, and it's associated with the urethra. So you call it the internal urethral sphincter. Now, the important thing about this muscle, this sphincter here, is it is innervated by a branch of the autonomic nervous system, meaning that it is involuntarily controlled. So we do not have control over the contraction or relaxation of this internal urethral sphincter, right? So whenever we go to void, when we go to urinate, involuntarily this internal urethral sphincter will relax. That will then allow urine to leave the bladder and enter into the urethra until it encounters the next sphincter, which is known as the external urethral sphincter, right? This external urethral sphincter is in fact innervated by a somatic motor neuron, and so it's under voluntary control, and so we're able to consciously control the contraction and the relaxation of this external urethral sphincter. Whenever urine flows through and we consciously and voluntarily decide to relax this muscle, we relax the muscle, it opens, it then allows urine to continue through the urethra and then be excreted through the body, right? So you can think of, since this internal urethral sphincter is involuntarily controlled, this is going to be made up of smooth muscle. This is voluntarily controlled, the external sphincter, so this is made up of skeletal muscle. right? So keep that in mind. And this process of voiding, this process of not controlling the internal urethral sphincter, but controlling the external urethral sphincter. This is known as the micturition reflex, which is the reflex of urination here. Okay. So when we look at the bladder, when you look at the urethra, it is similar in males and females, but it is also different as well, right? So first off, here we're looking at the female. You notice that there are more structures in the pelvis in the female than there are structures in the pelvis of the male. And so here we can see a couple of structures. So one, we see the rectum here, more posteriorly in the female. So this would be anterior, this would be posterior, this would be the pubic symphysis right here. So here you have rectum here, you have uterus right here, you have vagina coming down, and then anterior to both the vagina and kind of anterior and inferior to the uterus, you have the bladder here, right? And so you can see, so here's our bladder. We'd have our ureters kind of coming down, entering into the posterior margin of the bladder. This would fill, it would distend. As it distends, it kind of pushes on the uterus, and then from here, urine can then flow out of the bladder through the urethra. Now note here that the urethra, so the external opening of the urethra versus the internal opening of the urethra, they're relatively close together. So it's a relatively short urethra in females, whereas in males we'll see it's a bit longer, and this has some different implications, right? So here's the bladder in a female, here are the ureters coming in, and then here's the urethra as it would be leaving here, right? So in a male, you see similar things, but you also see some differences, right? So here you see the rectum posteriorly, you see the bladder anteriorly. You obviously do not have a uterus here because this is male. Males do not have a uterus. As you have urine fill up in the male bladder, you essentially go through the same thing. You're going to leave the bladder into the uterus, but you're going to pass through a few different structures, right? So in males, the bladder sits superior to this structure right here, this kind of round structure known as the prostate, right? In females here, females do not have a prostate, right? So there's a region of the urethra that passes through the prostate, so you call this the prostatic urethra, right? It then passes through this kind of membrane here, this region of muscle, so you call this the membranous urethra, and then you pass through this long urethra here that is contained within the penis, and so you call this either the penile urethra, or sometimes it's referred to as the spongy urethra. For reasons that we'll talk about when we do reproductive system. This blue tissue here, this blue erectile tissue, is known as the corpus spongiosum. So the or the urethra in the corpus spongiosum is called the spongy urethra, right? And so you can see here the urethra running through the prostate, the membranous urethra, and through the penis here in the male is much longer than the urethra running from the internal opening of the bladder, internal orifice, to the external orifice of the urethra in females. And so it's much shorter in females than males. And so this leads to an increased likelihood and an increased prevalence of urinary tract infections in females versus males because you have a much shorter distance between the external opening and the internal opening in females as compared to males. So there's some anatomical differences there as well, right? So here's the bladder in males. You see the ureters coming down where they would enter into the bladder. You see the prostate here. The urethra would pass through the prostate and then continue inferiorly. And we'll talk about some of these other structures, the role of the prostate, this gland back here called the seminal gland or seminal vesicle. We'll talk about those whenever we do reproductive system, right? Now, the urethra also transports different things in males and females. So in females, the urethra is only transporting urine, right? So it's just urine from in the bladder, carries it out, and excretes it. In males, you're also carrying urine, but you're also going to be carrying semen as well. And so semen is going to contain a couple things. It's going to contain sperm that's produced in the testes. It's also going to contain fluid from a couple of different glands. So there's a gland here called the seminal vesicle. You have your large prostate gland, and then you have this small one right here called the bulbourethral gland. All of these plus sperm are going to contribute to the volume of the liquid that we know as semen. So the male urethra transports urine and semen. Female urethra is transporting only urine. All right. So we can finish this part by looking at how aging is going to influence our kidney function, right? And so, like many things, as we age, the number of things, and sometimes the not necessarily the number, but sometimes the functioning of different structures tends to decrease as we age. So you have a decrease in the number of functional nephrons. So we said that roughly you have about 1 million nephrons per kidney, and so you can begin to lose function of some of those nephrons as you increase in age. You can have a destruction and damage to the filtration membrane, which can result in a decrease in your glomerular filtration rate. Other patients can have other complications, so they can have maybe heart diseases, congestive heart failure, that would then require them to take something like a diuretic. And so a diuretic in older individuals is going to influence the urinary system. You can have a loss of sensitivity to a different hormone, so like antidiuretic hormone. And so you may be losing excess water in the urine, excess sodium as well. The size of the bladder may kind of atrophy, may get smaller, and so you're unable to store as much urine, so you have more urinary frequency, and so you also may have nocturia, which is having to urinate at night. You can lose some of the tone of the bladder, as well as lose tone of some of the muscles controlling urination, so like the external urethral sphincter, which is under voluntary control, so you can have urinary incontinence. And then in males specifically, this prostate that we discussed, it's extremely common in males to begin to have a hypertrophy of the prostate, which results in an increase in the size of the prostate. And as we saw, you have the prostatic urethra running through that. And so if you have an increase in the size of the prostate and the urethra runs through it, and as the prostate increases in size, it begins to push on the urethra, that makes it more difficult for urine to flow from the bladder to the penile urethra, and it gets compressed in the prostate, and so you can have urinary retention due to an enlarged prostate. Now, some prostatic enlargements are benign, so there's something known as BPH, benign prostatic hypertrophy. You can also have prostatic cancer, in which you have a malignancy of the prostate, whereas BPH is a benign prostatic enlargement and not necessarily cancerous, right? It still has complications, but it's not malignant like prostate cancer is, right? So we will stop here. If you have any questions at all, please reach out, and I'll be happy to answer.